Welcome everyone, my name is Nicole Pates. I'm a paediatric physiotherapist with over 15 years experience and the director here at Western Kids Health in Perth. Today we're going to be talking about hypermobility in kids. What is it, whether it's something to worry about, whether we can diagnose it in children, and what to do if you think your child is impacted. I also sit on the Paediatric Working Group of the International Consortium of the Ehlers-Danlos Society, so this is a place where I'm deeply involved in both a clinical and from a research level. Let's dive in. So what are we actually talking about? Well, hypermobility just means joints that move beyond what we consider that average range. They're extra bendy, extra flexible. If you're a bit of a science nerd like me, think of a bell curve and that bulk in the middle, that's like typical, the average range. This bit on the end of the bell curve, that's extra bendy. And well, we know that hypermobility is genetic. It's passed through families the same way that your eye colour or hair colour is. And it's a feature of how the connective tissue in the body is built. It's important to know that hypermobility rates vary across different ethnic backgrounds and populations. We see a higher prevalence in African, Asian and Middle Eastern populations compared to Caucasian populations. So a child's ethnic background is relevant when we're thinking about whether their level of flexibility is typical for them. This is one of the reasons why we need to be careful about applying one-size-fits-all cutoffs. What this means practically is if you have a child from a family background where hypermobility is more prevalent, being bendy on its own is probably less likely to be a concern. It's the symptoms and functional impact that matter, not the flexibility score in isolation. And remember, it can look different for different kids. Some kids are flexible everywhere. We call that generalized joint hypermobility. Some are only flexible in certain spots, like in their shoulders or in their knees. That's localized. And some have really bendy fingers and hands. That's called peripheral hypermobility. But the key stat is around 10 to 25% of children worldwide show some degree of joint hypermobility. And that range itself reflects that ethnic and geographical variation. It's really common. But is it normal? Well, the answer is maybe, but yes, most of the time. I have to, check. You can see on the right in the graph from Ituan et al. 2025, published in BMC Musculoskeletal Disorders. They followed 126 children in Nigeria over 2 years with 3 measurement time points. Now, it's worth noting that this is a Nigerian cohort, which is a population with a higher baseline of hypermobility rates. Even in this group, the mean Beighton score, which we're going to go through in a minute, dropped consistently for both boys and girls. So generalized joint hypermobility throughout their body went from 25% to just 6% over those 2 years and those 3 time points. That's a massive shift. If it reduces this significantly in a population with naturally higher rates, that's really reassuring for families across all backgrounds. Girls do tend to stay a touch more flexible than boys. You can see that in the orange line, but the downward trend is the same. 3 key messages: it does change over time, and girls tend to stay flexible for longer, both are normal, and if there's no symptoms, we don't need to fix anything, so we can talk about that in a moment. I've mentioned the Beighton score a couple of times now. This image is from the Ehlers-Danlos Society and it shows you what the Beighton or the Beighton score is. And it's basically a 9-point scale that we use to see if we can measure how flexible a child or an adult is. So what we would do is we look at the pinky first. So you can see that that hand is flat on the table and we bend that pinky up and we're looking for 90 degrees. So if I'm here, right, that looks pretty like 90, yeah? But making sure that we do it flat so that we're getting true joint range is really important. So if you had that flexibility here to 90 on both sides, that'd be 1 point each. Then we do thumb to forearm like this, and we're trying to bring our thumb down to our forearm. Some people say that we should do it with a straight elbow, like, oh, I can't get myself in the picture, like this. You can see that like over time, I've stretched mine out by working with so many kids and families. This is my left, which I never use, and like, it can't get anywhere near. So 1 point for each thumb if they can touch that forearm. Then we look at elbow hyperextension. So we stick our elbow out straight. Does that bend past that straight line? 1 for each of those sides. And we look at knees. How far do they bend backwards? It's 1 for each knee. So that's 8 points in total so far. And then can you touch the floor with your palms flat and your knees straight? That's another point. So it totals up to 9, right? You can get a maximum of 9. For kids, the cutoff is 6 or more out of 9. In 2024, there was a meta-analysis in the European Journal of Paediatrics, which pulled data from over 28,000 children across 37 studies from multiple countries. This is important because it means that Beighton cutoff of 6 or more out of 9 has been validated across a diverse population, not just one ethnic group. However, the authors did note that the Beighton scores at baseline vary by ethnicity and geography, and that a score of 7 or more might actually be more appropriate for females specifically, but they need a little bit more data. So there is nuance here, right? The cutoff of 6 is the current consensus, but clinicians need to consider that whole child, their ethnic background, and the clinical picture. In the past, they were used cutoffs of 4 or 5, and that was problematic because we were over-identifying children as hypermobile, especially in populations where it was naturally, they're naturally more flexible. Moving to 6 out of 9 has meant that it's like we're getting to the end of that bell curve. So that's really important there. I also want to point out that this Beighton score is like a screen. It's not like if you're 6 out of 9, you're this hypermobile, and if you're 9 out of 9, you're this hypermobile. If you're 6, 7, 8, or 9, you're you have generalized joint hypermobility. You're not more severe if you're 9 out of 9 than a 6 out of 9. Like, it's not how it works. It's just you're hypermobile or you're not. Generalized joint hypermobile or not, which is really important because some people think it's like a severity rating. That's not what this is. I get asked all the time, can we diagnose kids? The short version, me as a paediatric physio, no. But generally, we try not to give a fixed lifelong diagnosis during childhood. So the 2023 framework from Tofts et al., which was published in the Orphanet Journal of Rare Diseases, uses like a sliding system. So under 5, we consider too young for any formal diagnosis. Because their bones are still ossifying. Like, if you look at the x-rays, you'll see the difference. And what that means is, like, is that bendiness truly joint laxity and that connective tissue, or is it just that the bones aren't mature yet? And then from 5 till skeletal maturity, we use this paediatric framework, which we're going to talk about in a moment. And after skeletal maturity, the adult criteria applies. At the moment, it's a 2017 adult criteria, but that will change at the end of the year. They're releasing a new adult criteria, the Ehlers-Danlos Society. But it's important to remember that framework that I'm talking about, that we're going to go through in a minute, before our pediatricians or rheumatologists can use this criteria to give kids a category of where they're sitting in terms of generalized joint hypermobility and symptoms. They need to clear other potential reasons first, like heritable disorders of connective tissue, think Marfan's or Sotos syndrome or Loewy-Dietz, other syndromic conditions, chromosomal microdeletions, skeletal dysplasias, and neuromuscular disorders. They have to be cleared before you can use the 2023 framework. As a physiotherapist, I cannot clear those things. And so I work with our pediatricians and rheumatologists to make sure that those things aren't happening. And it's really hard because kids change so much, and it's important that we consider everything that's going on. It's a little bit tricky, right? And like, I'm talking about understanding the groups here. You can see on the right, there's a Venn diagram from the 2023 Paediatric Diagnostic Framework. It looks complex. I'm going to go through it because it's a little bit simpler. It can make it look a lot simpler. But I like to think of it in 3 groups for families. You have generalized joint hypermobility. So I've done the Beighton screen, and you're either 6 or more out of 9. So you're generally hypermobile, but you might not have any symptoms. So that's asymptomatic generalized joint hypermobility. They're bendy, but they're doing great. There's no pain, fatigue, or functional impact. And they don't really need me or anybody, right? Then we have symptomatic hypermobility. And when we talk about symptoms, I want to stress that this doesn't have to mean pain. It can mean fatigue. It can mean not keeping up with friends. It can mean like losing steam quickly. And these kids with symptoms will benefit from support. So you can see on the right, when we look at that diagnostic criteria, there's some skin involvement and the musculoskeletal system involvement, like recurrent pain with activity, fatigue, dislocation, subluxations, that's that musculoskeletal subtype. And then we have our core comorbidities, which is the dark blue, and that's like, dysautonomia and chronic pain and chronic fatigue and things like that. And I will link the website from the Ehlers-Danlos Society for you so that you can go and have a look through that criteria. But remember, it's important that we don't fit this until you've seen the ped or the rheumatologist that have looked at all those other things and considered those differentials. And so it's the complex systemic stuff, it's where multiple body systems involved. The key message here is children can move between these groups. So a child who's symptomatic through a growth spurt, so they might get recurrent ankle pain after running or feel like they're always spraining their ankles, have some knee instability episodes during a growth spurt, they might shift back to like having asymptomatic hypermobility if we build their strength and their capacity, right? And but if you have the skin stuff, you always have the skin stuff. But things can evolve, and so one of the important things with this framework is it's not fixed. Kids can move as things can get more trickier. We can go in between those little circles, and that's where you work with your rheumatologist or your pediatrician to really understand where your child is at. Just because there's no diagnosis of Ehlers-Danlos syndrome, it doesn't mean that we can't support your child. And what this framework on the right here in the Venn diagram actually does is it helps us understand what's happening for your child and how we can support, what best management is there that we have through the literature and clinical experience that we can do to support your child to help them participate in life as much as possible. So the framework guides the intervention, even though there's no specific diagnostic label. I think what's important to flag is connective tissue isn't just in the joints, right? So yes, there is muscles and joints, they have connective tissue, that's obvious. And you might see things like with our really flexible kids or our generalized joint hypermobility kids, you might see pain after activity, they might fatigue, they might have fatigue more than their friends, they might have easy injuries like spraining your ankle all the time at 6 and 7. That's not normal. Come and check in. Let's support and stop that from happening. Knee dislocations, like them happening over and over again, not normal. I want to flag growing pains here too, because a lot of people have been to see their doc for growing pains, and sometimes, it's something that we want to look at the pattern and pay attention to. Is it after activity? Is it limiting them? Is it interrupting sleep? All of those things, definitely something we can help. In terms of sleep, it can be associated with things like restless legs and difficulty sleeping at night and increased movement during sleep, and that crash by the end of the week, your Friday afternoon meltdowns. A 2025 Swedish study by Sherbet, I can't say this word, Hjalmarsson, found hypermobile adolescents had significantly more nighttime movements than controls. So if your child's waking up tired despite being in bed for a reasonable amount of time, and sleep quality might be worth exploring. Gut and bladder. So lots of kids get constipated, right? We know that, but constipation, IBS type, swinging between constipation and diarrhea, toileting delays, so like that delayed toilet training, or holding on for really long time periods because that bladder can really stretch and then they really need to go really urgently, or constant bedwetting. They're sometimes things that you will find and probably worth checking in for. So if they're having continence issues or current constipation, we can, our team can support with that. Your multidisciplinary team can support with that in conjunction with whoever you're seeing from a medical perspective, whether that be your pediatrician or your gastroenterologist. In terms of skin, there is connective tissue throughout our skin, so it's soft, stretchy, it bruises easily, there's stretch marks, unusual scars, and scars might be really shiny over time. These skin features sometimes develop later, so you might not notice them in younger children. And if there's significant skin involvement alongside joint hypermobility, that's something that our rheumatologists will monitor really closely. And our emotions, anxiety and depression have been shown to be more common in people who live with pain. But there's also a specific neurodevelopmental link. Kindergarten at L 2020 found that there was a slightly higher, like the percentage of kids with ADHD with hypermobility conditions was about 16%, which is higher than the general population. There's also some thoughts around autism presentations being seen potentially could be higher as well, but it's emerging research. What's tricky is the research, like look at those Beighton scores, because some of the research is still using a 4 or 5 out of 9 for Beighton, and that's not giving us really clean data. So when you're reading research, please check that. But I think that interplay between neurodivergence and pain can impact sleep, fatigue, sensory processing, and how kids feel and participating and engaging with their day and school and their friends. If your child is hypermobile and neurodivergent, like we consider both of those things when we're working with your kids and your families to come up with plans about how we're going to help them. In terms of the autonomic system, this is one parents often haven't heard of. And some children do experience dizziness when they stand up. They have difficulty coping with heat and nausea or dry eyes and mouth. And the autonomic nervous system is not potentially really regulating as it should be. Sometimes there's racing hearts or like fainting and things like that. There's lots of management we can do, so increasing water and salt intake, exercise rehab to improve that capacity of the muscles to support that system and our system to work in itself, compression garments, lots of things. But if you're finding your child is having some of those symptoms, like they're getting dizzy or lightheaded, it's worth mentioning to your clinician. I think what's important to highlight here is if your kid's having symptoms across multiple of these areas, let's help them and help them soon, because it's tricky if it goes on for a long time. Handwriting is probably the most common concern we hear from families, but it's one that can also fly under the radar for a long time before anyone connects it to really flexible hands. Children can spend up to a third of the school day handwriting, and that's a huge amount of time. And for a child with really flexible hands and wrists and developing bones, it can be harder than it needs to be. So effective handwriting requires a stable wrist and controlled movement of that thumb and index and middle finger in that what's considered a tripod grasp. I don't have a very good grasp. So when there's hypermobility, sometimes it's hard for little kids to get that stability naturally, and they have to work harder to control their pen. Their muscles might get tired quicker, and because they're doing a job that the ligaments would normally help to provide that stability. And we see kids compensate with weird grips or tight grips or using their whole palm. And they might look like the child is holding the pen wrong, but actually they're trying really hard to create a stable system so that they don't have to work as hard. But the problem is these compensating patterns restrict that nice fluidative movement, increase the strain on the wrist and the forearm, and ultimately, long term, can make things a little bit worse, not better. Wesley et al., who's a fantastic OT from over in Sydney, in the American Journal of Occupational Therapy, documented that kids with hypermobility have reduced grip strength, reduced in-hand manipulation, and reduced finger dexterity. And over time, this can lead to writing avoidance and reduced written output. When a child is producing less written work than their friends day after day, week after week, learning gaps develop. In that 2021 study, Alice and Wesley also reported that it significantly impacted the child's education. And it's one thing that might get missed. Kids might be really bright and engaged and really capable, but physically getting their ideas onto paper is a bottleneck. And that's incredibly frustrating for the child and for the family and for the teacher. But on the bright side, we can actually help with that, and our OTs are fantastic. So please, if this is something happening for your child, don't give up on handwriting. And if you notice it early, please get in touch. But even if you notice it later too, through later primary school and high school, because we're here to help. Okay, I've included this slide because I'm a physiotherapist and I work with my podiatry friends, and it comes up, flat feet comes up in almost every parent conversation. Child gets flagged, they have flat feet, someone suggests orthotics, and suddenly you're wondering whether you need to spend hundreds of dollars on custom insoles for your 4-year-old. So let's talk about the evidence. First, flat feet in young kids is just frequently a normal expression of developmental foot and ankle flexibility. It's not a pathology and it's not a problem. Martina Hines, Sebastian et al. In 2025, published in the Journal of Paediatrics and Child Health. They looked at 196 children aged 5 to 10 and found that foot posture was significantly correlated with foot and ankle hypermobility, and that hypermobility naturally reduces with age. In other words, flat feet are largely explained by the same developmental flexibility that we see everywhere else in a child's body, and it tends to improve as they grow. They get stiffer. In the Evans et al. Cochrane review from 2022, they looked at whether foot orthoses change outcomes for pediatric flexible flat feet. Wow, that was a mouthful. The answer is no evidence that routine orthotics make a difference for asymptomatic flexible flat feet. So if your child has flat feet but no pain, no functional issues, no problems with activity, they're not super tired in their legs and their feet, there's no evidence that you need to put them in orthotics. But here's where I need to be balanced, because the picture does change when there is pain or fatigue or tiredness in their legs, or that they're just not keeping up. Pearson et al. 2018 published a systematic review in the Journal of Foot and Ankle Research looking at that physical and mechanical therapies for kids with hypermobility. And they found emerging evidence that supporting like orthotics, prefab and custom to reduce pain for kids with hypermobility. And that's been found, supported by Marge et al. 2023. In their study, they also found that custom orthotics also reduce lower limb pain, improve quality of life. So yeah, orthotics can help. But the key, and this is really important, is that it works best when it's combined with a tailored strengthening program. It's not orthotics instead of exercise, it's orthotics along exercise. The orthotics provide some external support and improve mechanics, while the exercise builds the capacity of the muscles and the system. The strength work kind of addresses the underlying issues, and the orthotics help manage the symptoms while that capacity is building. I think what comes to mind most is, why do some bendy kids, why do some hypermobile kids struggle and others don't? And I want you to think about this slide, because hypermobility on its own doesn't necessarily cause problems. We know that, right? Plenty of kids are hypermobile or bendy and thriving, but symptoms pop up when the load outweighs the child's capacity to cope. And when that balance tips, that's when we start to see pain, fatigue, avoidance, and a downward spiral that I'm going to talk about next. I'm going to give you an example. But let's walk through the capacity side first, because this is where our power is. Strength, building strength of the muscle system, building your body awareness, your balance, your what we call proprioception. Muscles are like the dynamic stabilizers of our joints. If we have lots of flexibility and lots of range, your muscles have to work harder to do their job. So building strength helps that control. But if it has to be something they want to do, because if I tell them to drop and give me 20, or it's 30 squats or 30 burpees, they won't stick with it and it won't work. Kids are growing all the time, and like variety is the spice of life. We might not stick with one sport or one exercise program. We mix it up so that their body keeps adapting as they're growing taller and heavier. I spoke about proprioception, or good balance and body awareness. That's where your body sense is in space. We know from research that symptomatic hypermobile kids, their proprioception is affected. They have motor control challenges compared to asymptomatic kids. And so we need to build that. Good sleep routines, that's really important to build capacity. It's where the body recovers overnight. Gradual loading, so not doing too much too fast. We need to build up programs so kids can feel confident in their bodies. It's really underrated. I think it's really hard, because some of our kids with hypermobility, symptomatic hypermobility particularly, they roll their ankle when they're running, and then they feel a bit nervous about running, so they kind of do a little bit less, and then they roll their ankle again, and so their confidence is shattered, and so then they kind of start to do less. Confidence in keeping up with their friends. Kids don't exercise for health. They don't want to be I'm going to find 30 to be fit. They exercise because it's fun and they want to do what their friends are doing. They want to play. And when they can keep up and they can stay in the game, it's awesome. When they can't, they pull out, and that's not good. So, and also a supportive environment at school and home. So teachers understanding, parents understanding, and that the pain is very real, and that scaffolding from parents and teachers really matters. Okay, now the load side. So growth spurts, especially puberty. Puberty has a very interesting effect on our whole body, not just our musculoskeletal system, but our hormones and our autonomic nervous, everything gets impacted by puberty, our sleep systems. But in growth spurts, bones tend to grow quickly, muscles have to catch up, and for kids that are flexible, that we need strong muscles for, that mismatch can be tricky. And for some of our hypermobile kids, this is a really vulnerable time. They have to work harder, and this is often where we see symptoms appear for the first time. Deconditioning. So this is a big one, and it happens really fast, like even 2 to 3 weeks sometimes for our flexible kids, like over the school holidays. A really nasty virus that knocks you out can tip the balance, and muscles lose conditioning quickly, and when they try and come back, the load's the same, but their capacity's dropped, and that is enough to, mismatch is enough to like trigger pain and symptoms. Transitions, so starting primary school is a big physical, social, cognitive change, new routines, new expectations, longer days, no safe spaces, can't chill out on their own. And moving from primary to high school is even bigger. Bigger campuses, heavier bags, longer distances between classes, more PE expectations, social pressures ramp up, different teachers, like, it's a lot. And sometimes for our kids that have a neurodivergent, primary school, you've just got used to that routine and you know how you can cope. And then moving to high school, a really big tip of that balance. That these transitions add load across the physical, social, and psychological domains all at once. Poor sleep or sickness. So we've talked about being unwell for a week or two and the deconditioning effect, but sometimes like that sleep deprivation can compound everything. So if you think about we go into high school and social stress and we're on our phone all the time, and potentially we're like worried about things, that sometimes there are things impacting sleep that can tip the balance, and kids can become symptomatic. They start to get pain and fatigue with their hypermobility. Major life changes or stress, a family move, there's separation, potentially a new sibling, changing schools, friendship difficulties, a pet passes away. Sometimes it's not even like big things like that, it's like lots and lots of little things, lots of multiple tests in a row combined with swimming competitions or other things. These put load on our nervous system, and the body's stress response doesn't distinguish between a physical and like a psychological threat. So when the nervous system is in protect mode, pain sensitivity goes up, fatigue increases, and our threshold drops, and our kids get symptoms. Injury and surgery. So an injury can take a child out of activity for weeks or months, and again we get deconditioning, but also the psychological impact, like the fear of re-injury, loss of confidence, avoidance behaviours. All it takes is one bad dislocation or a painful experience in a sport, and that kid might be not feeling the best about going back. So when you look at this slide, what you're really seeing is the hypermobility is there in the background. It's always there. What changes is everything else around it. And that's actually really empowering, because it means there's a lot we can do. We can build the capacity side up. We can anticipate the load side. We can prepare for it. We can catch the early signs of that balance tipping and step in before the downward spiral takes place. Key message for parents is you can't change the hypermobility itself, but we can absolutely change the factors around it. And that's where the work happens. Okay, so this is a really important slide to me, and I want to give you an example that I see very often in clinic at Western Kids with the kids. And I want to take the example of a 4-year-old here who has some, or maybe 5-year-old, a 4 to 5-year-old with decent ankle flexibility. So they have flexible tendons and lots of ankle movement. And because they've got, like some kids can even bend their toes all the way to their shins, but some have just a little bit less than that. Some of those kids with lots and lots of movement through their ankles, it makes it really hard to develop the spring for running and hopping. So they might do a few hops or run a short distance, and that's okay, but doing it over and over again, it's really hard. That endurance just isn't there. So if you ask your kid to hop at the age of 4, they should be able to hop 5 times in a row. If they can't hop 5 times in a row by 4, I'll be like, okay, let's support them, and I'll tell you why in a minute. But if they're hopping and they're getting really tired, or saying, Mum, I can't keep up with the kids in the playground, it's really important to us, because the running and the hopping doesn't build the same way it does for other kids, because that springiness isn't there, and that it's different. So they can struggle to keep up, or it starts to hurt, or they just get really tired. It becomes less fun, they pull back. So when there's less conditioning, like less running, less activity, it means deconditioning, which means less strength, which means less like building fundamental motor skills that we normally build through childhood. Movement doesn't develop at the same rate, and the gap with their peers widens. That's not good. So then what we see is their confidence dropping, and they withdraw, and that cycle deepens. And that's why I want to stress that symptomatic doesn't have to mean pain. It can mean fatigue, not keeping up, or not having the same skills as their peers. And interrupting this cycle early is so important. We don't want to wait for pain. We want to look at the early signs and step in. So if you've got one of those 4-year-olds or 5-year-olds that's really struggling with running and keeping up with their peers, please check in with a physio and let's build those skills, because it can have a very good future impact to address it early. Okay, and everyone goes, well, that's all great, Nick, but when do I actually see someone? When do I need support from a paediatric physio, OT, or a psychologist, or my rheumatologist? And so firstly, trust your gut. You know your child best. If you're worried, check in. You'll either get a plan or peace of mind that everything's going okay. But pain, definitely check in. If your child has ongoing pain or recurrent pain, that's not normal. Please check in, regardless of whether they're hypermobile or not. And if it's limiting what they want to do, especially check in. Fatigue, so if they're really, really tired, please check in. It's something that we don't talk about enough, and that really impacts day-to-day life. Multiple or recurrent injuries, so spraining that ankle over and over again, or easy dislocations. Avoiding sports or PE for fear of getting hurt or fear of pain is really important. Like if they're like, oh no, I don't want to run, I really don't want to sprain my ankle again, that's when we need to give support. Not keeping up with peers physically, struggling with handwriting, dressing or cutlery, buttons, things like that. Difficulty walking long distances, like you find you're still needing to use a pram at 5 and 6, just really tired and they can't keep that endurance up. Ongoing sleep difficulties or restless legs, any of those, incontinence or bladder, or gut, like the constipation or the constipation to diarrhea swing, check in. Dizziness in standing, all those temperature things we talked about, or if you feel like they're anxious or they have low mood, please check in. Trust your gut. You know your child best. I hope that this has been informative for you today. Please, if you have any questions, I'm here to help. My team's here to help. Reach out. We'd love to chat more. You can contact us through westernkidshealth.com or via Instagram at westernkidshealth.